From my own clinical work, I find quite interesting that when someone comes to me for treatment of insomnia or other mood disorders, I often check their sleep quality, how they sleep. And sometimes they will mention themselves have some kind of sleep symptoms that out of the scope of insomnia. Or they will tell me that either their spouse or their parents actually snore heavily, quite loudly for years. And I often tell them, well, other than our treatment to you for whatever your major complaint is, I think we need to consider either for you, your spouse, or your parents to have a sleep study done, which is a testing in a sleep center. And they often ask me, what is a sleep study? What is sleep testing? So today we have Dr. Khosla to really share with us what it's like to have a sleep test, a sleep study done. And during COVID, what many sleep centers, especially their sleep center, have done to really protect their staff and the patient's safety. Dr. Khosla also shared different types of sleep disorders and how sleep study can really help with the process of diagnosis. Also, what are some appropriate treatment for certain sleep disorders once you get the diagnosis through a sleep study, for example, sleep apnea, and in their center, how she follow up with patients through telehealth. So if you or your family are struggling with sleep disorder or are waiting to get sleep study done, but because COVID, you are encountering some difficulties, hopefully this episode can give you some ideas what it may look like right now and to help you reduce your anxieties about visiting a sleep center under COVID. Welcome to Deep Into Sleep. I'm your host, Yishan. Welcome, Dr. Khosla.
Thank you for having me. I appreciate it.
So I'm really happy to have you here. I have quite a lot of questions for you. So I know you're the medical director at North Dakota Center for Sleep. And so I'm curious what you do there. What's your specialty locally in the sleep center?
Sure. So I am a pulmonologist. I did a fellowship in pulmonary critical care and sleep, but now I do 100% sleep medicine. So I see clinic patients and we do sleep testing both at home and in the lab, and we take care of any sleep disorder, not just sleep apnea. We take care of insomnia and restless leg syndrome and narcolepsy and idiopathic hypersomnia. So we take care of any sleep concern that somebody may have.
Oh, that's great. So sounds like a very wide scope. You can see a lot of sleep disorders there.
Well, and you know what I've always found really interesting is that, I think sleep is a great equalizer. No matter who we are, whether we are educated or not, or wealthy or not, we all need sleep. And so it's something that, we really can't afford to ignore. And so many of us have undiagnosed sleep disorders, or we have this attitude of, well, that's as good as it's going to get, and I need to accept that.
Yes, exactly. And also as a psychologist myself, I find sleep topic is such a good way in for other mental challenges, and people love to talk about sleep and are okay with sleep. There's less stigma attached to that. And then when we start talking about sleep and treating sleep, and many other things can slowly happen.
You're right. What a great viewpoint. You're exactly right. And why is that? We do have this mental health stigma. And I think you're right. There's such overlap between our mental health and our sleep. So I'm really glad that you can use that to open the door and engage your patient that way. Do you find that it makes them more willing to share with you?
Yeah, more willing for me. I think it's make them more willing to share with me, and they start realizing, seeing a therapist, seeing a psychologist, and it's not that scary. And actually, on my sleep symptom, especially insomnia, for me to treat, my insomnia can get better. And then in the process, I realize, oh, actually, I'm anxious. Or actually, I feel sad often. There may be some other things. Then I think it's just a higher level of acceptance to be willing to face whatever the deep challenge they have.
Well, isn't that interesting? You know, I joke about this a lot, but in our sleep clinic, we go through a lot of Kleenex, and my friends make fun of me because why do you make your patients cry? And I said, well, you know, it's not. I think so much of like you talked about with insomnia is for some reason, I think we have been programmed to believe that if you have insomnia, you need a prescription for a pill and that's it. And really, I think we kind of owe it to our patients to try to figure it out a little bit more. And so, I don't know, you kind of hear a lot of childhood sexual trauma, and you hear a lot of marital issues, and you hear a lot of the other things that are contributing to insomnia. And then when people have this, I mean, I suppose it's kind of like a safe space to talk about it. You can see that they start connecting the dots, and they realize that, oh, this is why I'm not sleeping. And yeah, I see why you think I need to go see a therapist. I found it interesting that you said that people are somewhat reluctant to see you. And I wonder if that's something that we probably share, that a lot of people that are in sleep clinic are there because their wives or husbands have sent them, and they really don't want to be there, and they really don't want to have a sleep test, and they really don't want to wear CPAP. But then
Right.
if you can pull that out like you do with your patients, and you show them how the thing that really bothers them might be linked to something that they are a little bit uncomfortable talking about, and then you lead them and you connect them to that, and I think that's very impactful.
Yeah, I totally agree. I think we definitely share some of this experience, and we definitely see how good people are at avoiding things. Yeah. And I also know a lot of different sleep disorders other than insomnia, like narcolepsy. It can really harm or impact our quality of life.
Isn't it amazing? Narcolepsy is such a tough one. You know, I think people for lay people, I think a lot of people think it's funny, right? It's comical,
Mm-hmm.
like the guy on TV who falls asleep in a soup, and people
Mm-hmm.
think it's really funny, and they don't realize how debilitating this can be. And it's more than just falling asleep, right? There's
Mm-hmm.
so much more to it. I mean, think about how that impacts you day to day when you've had a night or two of not sleeping well and you're exhausted and you can't think the next day, right? Imagine if that's your everyday.
Yeah.
And then
How
trying
to,
to articulate that to your family and your
right.
friends and people who don't
Oh,
understand, and who think that you're lazy, or that you just, why don't you just go to bed earlier, and you're just spending too much time on your phone, and they don't get it. And I think that is one of the hardest things, I think, for our patients, is that if you have a diagnosis like cancer, for example, everybody understands that, and everybody kind of gets that it's not your fault, and this is a horrible thing that happened to you. And when you deal with something like a sleep disorder, I think there's not that same understanding. I mean, I'm not equating the two by any stretch, but there is still that idea of people have sleep disorders that profoundly impact their day to day, and yet so many people assume that they're lazy, or they're doing it to themselves, or they're just staying up too late and that's why they're sleepy, without recognizing that there may be a true underlying sleep disorder, that no matter how much they sleep, they still don't feel rested.
right, exactly. I think that's such a important point for a lot of people to know, that this layer of stress, this pressure, they not only add to themselves, they're confused, what's going on with me? Is there something wrong with me? Am I just lazy? And there's so many like external stress from people around them. I know people who are diagnosed with sleep disorders, lost their lovers, their partners, and people around them just don't understand, think they are weird. and some of them have to quit their job and cannot finish their school. It's quite challenging. It could be really severe.
It really can. And sometimes even, I remember this nurse years and years and years ago. She always worked nights, and I knew her from my pulmonary days and critical care days. And she had narcolepsy. And it was one of those things that it took her a long time to get a diagnosis, and she managed it very well. And she just chose to be a night shift worker because that worked better for her, and she was very successful at it. And so I think with the right support and the right treatment, yes, people can have these very full functional lives, but that social support is so important. So her husband was very, very, very supportive of her. And I think that made a huge difference for her and her outcome.
Yeah, definitely. If people we love, people around us really understand or try to understand and try to learn how to support us, how to support patients who are struggling with some kind of sleep disorders, that's definitely, even psychologically, I think that make a huge difference for sure.
Yeah, and I think the same even goes with CPAP. So spouses who accept the CPAP, I think, and they're very encouraging. So one of the complaints we get in clinic all the time is, CPAP just isn't sexy. I don't want to wear this. Right? It comes up all the time. And and you try to switch it, you try to say, well, but it's a lot sexier than like the gasping and choking. And if this person really cares for you, right, it's not going to, it's not going to be that big a deal. And I know, that if you look at somebody that you care about, you feel better knowing that they're on a CPAP. Right.
Right.
And so it's just one of those. I had one lady years ago now. She had gone through a divorce, and she was dating, and she came into clinic, and she's like, so listen, my boyfriend is going to spend the night for the first time. She said, what do you think I should do with my CPAP? And I said, well, I want you to wear your CPAP every time you sleep, right? So I want you to wear it, but ultimately you have to decide what you want to do. And so she really thought about it, and she put her CPAP away. And her boyfriend came over to spend the night. And the first thing that he did was unpack his CPAP. And then she looked at it and she said, great. And so she unpacked her CPAP. And they wound up getting married. It was such a lovely story.
Wow, that's so sweet. Such a great example.
So yes, they were both very supportive of each other. And so I thought that was really kind of cute. She was very excited to tell me about that next time we met.
Yeah. So that CPAP, I know it's type of treatment. And you mentioned sometimes it takes a very long time for people to get diagnosed, get the right treatment. And some guests I interviewed on my podcast before, they had similar problem, took them like years, like some of them around 10 years or more than 10 years to get a diagnosis. And so I know one common way to be diagnosed with sleep apnea, for example, is sleep testing and to be in the lab, or there are other ways, right? What's the barrier for people to get diagnosed?
I think so much of it depends on whether it's on your radar or not. So if what we've seen is that, especially as women can be underdiagnosed because we don't necessarily have the same symptoms as men. The guys all they read the book, right? So they gasp and choke and turn blue, and their bed partner says, honey, you need to go in. Whereas for women, we sometimes are a little bit more subtle, and we have more apnea maybe in, later in the night when our bed partners are asleep. And maybe we have insomnia rather than hypersomnolence. And so a lot of the time as women, we get treated for the hypertension and the depression rather than the sleep apnea that might explain all of it. And so I think that has been, you have to be able to think of it before you can diagnose it. The other limitation, I think, has been testing. So you're right. We've always had this in-lab test, which is a great test, but it is, it's a lot of wires and you have to come in and be away from your family and there's cost associated with it. There's a home sleep apnea test which is kind of nice that you can do it at home. So if you ask the question, is a home sleep apnea test as good as an in-lab study? The answer is no. But if you ask the question, is home sleep apnea testing good enough for regular obstructive sleep apnea? The answer is yes, with an asterisk, right? So if we catch it at home, great. But most of the tests that we use at home they can't tell if you're awake or asleep. And so then you won't have sleep apnea if you are awake. And so then the numbers get watered down. And so one of the things that we've been trying to do is, so forever, we have really been trying to show people that sleep is really, really important, right? And there's been this cultural shift, I think, where we used to be very proud of staying up all night, right? It was this badge of honor. Yeah. And now people are really making it this cool thing that, hey, this is my eye mask and I'm going to go to bed now. And this is my bedroom and look how great it is for sleep. They're really making that more important, which I love. They've made it very glamorous now to just go to sleep. And so part of that, I think, is that we have this heightened awareness of the importance of sleep. And I think we owe it to our patients to make it easier to get tested. So a lot of testing is in the home now. One thing that we have been trying to do is make it even more accessible. One of the bottlenecks is, well, you have to go to your doctor and you have to get a referral and you have to do this and you have to do that. So,
right.
People get tired, right? They don't want to make 10 trips to do one thing. And so we're trying to figure out how we can improve sleep health. And so we know from various studies that 80% of sleep apnea is undiagnosed. I mean, that's huge.
That's a very high number.
It's very high. And I think a lot of the time people are like, yeah, I probably have sleep apnea, but I don't want to wear CPAP and I don't really care. And so I think it's a matter of showing them that, well, sleep apnea actually is an important thing. It's more than just snoring, right? And these are the things that can happen to you. And how can we make it easier for you? Treatment doesn't have to be a CPAP, right? There's lots of ways we can treat sleep apnea. Let's find something that works for you, right? Let's try to figure it out. So if you look at, and this is something that everyone's talking about, but there hasn't been really good data yet. But if you look at the patients in New York with COVID, the top 3 populations of people who didn't do well: diabetes, hypertension, and obesity. That's kind of the trifecta of obstructive sleep apnea. And if you factor in 80% of those are probably undiagnosed, right? Is sleep apnea playing a role in why people aren't doing well? I mean, we know sleep's important for our immune system. We know that sleep apnea has this inflammatory component. Right? So is this part of it? So then, of course, we bring it back to our family members, right? And so my mom's on a CPAP, and I'm very, very careful to make sure that she stays healthy. And, my brother delivers groceries to her. My mom and my brother both live in Canada, where I'm from. And my mom's a family practice doctor. And I've been teaching her how to do telemedicine because I don't really want her to go physically see patients. And so like, Mom, make sure you clean your CPAP. Mom, make sure you wash your hands before you touch your CPAP. Like all of these things, right? And so we're trying to do that to our patients too. With COVID, we've had to shut down the lab. And so this has been really hard because we know that sleep apnea is really, really important to diagnose and treat. But we also want to keep patients and our staff safe. So it's kind of funny. We've done a crazy amount of things to try to do that. And if I showed you all of the documentation and all of the plans that we've had, you would laugh. Wow. Because it's really, we've got so many different versions because things change all the time. Right. So I'll send out an update, to my colleagues. And I swear, as soon as I hit send, some other article will pop up.
Oh no.
And so now we have, so I wear different hats in my life. So I've got my clinic hat in Fargo, but then I'm also medical advisor for a larger company called MedBridge Healthcare, and they do sleep testing across the country. And so then we're having to look at, the lab in New York, for example, and in North Carolina, and in the Dakotas, and in Minnesota, and in Iowa. Like what can we do differently? And how do we figure this out overall as a company to keep everybody safe when there's so much variability, in the region? So we kind of always go back to, okay, would I put my mom in the lab, right, as a patient or as a tech? And so we have PPE for our techs. We screen our patients twice. We screen our staff.
Wow.
So our labs used to be really, really pretty, like these really pretty, they look like hotel rooms, just beautiful labs.
Right.
We took all of that sort of pretty stuff out, like all the little, like the clocks and the little decorative things. We took it all out because we didn't want that to be a source of infection. And then we're really picky about who gets into the lab. And we we have this ability. There's a website that lets you look at coronavirus per county.
Yeah.
And then you can look to see whether it's going up or going down, and whether it's fast or slow or whatever. And so then we kind of make a plan for that lab in that county according to what's happening. And then we have these boxes that we invested in, these UV boxes. And so then our techs can disinfect their phones and their keys, whatever. And the rooms are all swept down, and we have mattress covers that are wipeable and pillowcases that are wipeable, and all of these things. And we have viral filters in there, and we have closed circuit systems. I mean, it's unbelievable. All of these things that we're trying to come up with just to keep people safe. And also, we're just not, we're converting as many people to home testing as we can. We're using disposable equipment. I mean, this whole thing has really upended our sleep world. And so we still feel this obligation, right? Like you still have to take care of your patients, and you still have to protect your staff. And if we're going to be dealing with this for 18 months, we better figure out how to do it well.
Yeah, that's amazing. A lot of really details you all have to manage and pay attention to, especially when it's like nationwide, different locations. That's a lot of work. But at the same time, I think as potential patients, when they're hearing all these steps, when they can see all these changes, they do feel safer.
I hope so, because that's our goal. So at first, the easy thing to do was just say, "Oh, we got to shut everything down." And I was talking to a friend of mine, and he made me look at it differently. So he had a patient who was young-ish, right, sort of mid-40s, I think, or something, who was supposed to come in for sleep study. And because of COVID, he didn't get to come in. He didn't get to come in. He didn't get to come in. He got delayed. And when he finally came, his oxygen level was so low, they sent him to the ICU.
Oh, wow.
and so he was upset because, he's saying, you guys were not, this is not right either. And I said, well, you're right. It's not right. So we have to figure out who, we have to sort of do that assessment of, it's really important for this guy to get in, whereas this guy can probably wait. Right? Or maybe this guy, we can start on CPAP without a test, but I don't know, right? We're doing all telemedicine, for example. Like we just shut down our clinic, and I see patients, via telemedicine now. And so that's been a change. I mean, I've done telemedicine for 10 years, but I've never been able to do it in someone's home. We always did it from our clinic to someone else's clinic, right? And so it's familiar, but it's still different when you have it in patients' homes. So that's been interesting, and I think above all, we all just, you have to do what's right for your patient. Like that's what it comes down to. You just have to do right by your patient.
Yeah. And because sleep apnea or different sleep disorders can still be very severe and can lead to like really bad health consequences. So that's another level of safety.
No, you're exactly right. And, I mean, you don't want sleep apnea. You're right. It does cause, stroke and high blood pressure and diabetes and memory problems and all of that. So it is really important to treat. So when on paper, when the CDC says, okay, well, this is an essential service and this is not an essential service, I mean, I get it. Getting your toenail removed is probably not super emergent, and having your heart attack, that's emergent. That's really, really clear. But I think what's less clear is this sort of middle ground that, okay, today your sleep apnea is probably not going to kill you. But if we wait 2 years, we probably, that's not great either. And so there has to be middle ground. And how can we do this safely for everybody involved? I think that's a huge concern. And it's definitely not sleep only. I mean, what about your practice? Are you seeing telemedicine patients?
Yeah, so my practice is all like we are therapists, so we have switched mostly, I would say, to telehealth. But for high risk patients, like for patients have suicidal ideation or even intentions or some kind of plans, we think they're in danger. We are trying to still see them face to face with masks on. With I tell all my therapists we have to have certain regulations to make sure everyone's safe. So we are trying to wipe the whole office every day, all that. So definitely, I think it's a adjustment for all of us across different settings.
Isn't it funny too that how your office changes? So even the week before we finally shut down our clinic, we didn't let anybody sit in the waiting room. We'd make them wait in the car, and we didn't let other people come to the appointment. It was just, and my clinic is small, and it's hard to get 6 feet between my chair and the patient, where the patient sits. But we did try to move everything as far as we can without it being so obvious that like shouting across the room at somebody. But it's the things I think that we've done forever. I've been there for 11 years. And you get used to the way things are. And then I think it is important to look at it and say, okay, well, hang on. Why do we need this? Like, we got rid of all our magazines in the waiting room. I'm like, oh yeah, we probably don't need those. That's probably a good thing. We don't have a candy dish anymore. We used to have coffee for our patients and that sort of thing. So we've kind of gotten rid of all of that.
Yeah. It is very interesting. I hear stories from my colleagues. They are actually changing their office. They totally switching offices because their old office is too small to keep 6 feet. So they are actually moving, try to rent a new office can be a little bit larger. And for me, myself, I try to have a couple therapy with, multiple people in the session together. So all of us, like at least 3 of us, sometimes family therapy has more people. We all have to wear facial masks, talk to each other, keep a certain distance, be very cautious, no handshaking anymore for 1 to 2 hours. Sometimes the session goes really long. It's very, very uncomfortable.
So I bet that is hard then, because people read your facial cues.
Right.
So have you found that that's been a challenge, wearing a mask?
Definitely. And it's harder for me to read their facial cues too, especially as a provider for therapy. I want to know what's going on, and there are subtle dynamic between couples, within a family. So I would say definitely it brings more challenges. And I'm still trying to get used to how to just get enough information from their eyes, from their body gestures in session.
It's hard though. That was one thing that when I'm imagining, because some of our patients have not wanted to do telemedicine. And so we're trying to figure out, well, when will we open the office again? And we'll probably still do telemedicine and then have an in-person person maybe at 9, and then do 2 telemed patients and then have another person come at like 11 so that we're separating them. But then I also was thinking about, well, part of what I do when I evaluate them is I look at their, I have them open up their mouth and I look at the back of their throat. So for me, I've actually been able to get that really well not always, but pretty well with telemedicine. And it's funny in some respects because I'm trying to guide people to show me the back of their throat through their camera phone. And so I've looked at a lot of ceilings. I've looked at a lot of noses, a lot, and so that's been interesting. I haven't quite gotten it down for how to convey how to do this to patients, and it depends on if they're on a tablet or a laptop or on their phone. And then I have an Apple and I don't have an Android, and I'm not really sure where the camera is on an Android, but I need to figure that out so that I can help my patient get a better view. and so that's been interesting. And so I feel like that is in many ways safer than me actually, opening up their mouth and taking a look.
Yeah, for you, sounds like totally that actually could be risky if you have to be so close to them and really need to have a closer look to their throat. And if the camera angle is right, that could be so much more clear. With nowadays, the technology, the camera actually are quite good.
I'm actually surprised at how good some of them, of course, it depends on their internet connection and their phone and that sort of thing. But some, I'm just kind of amazed. I've been taking these pictures even, just to show, I'll grab a screenshot sometimes. And then I will share my screen and show the patient what I'm looking at. And I'll show them like, this is that dangly thing at the back of your throat and it's really red. And this tells me that maybe you have sleep apnea. And so then it's really interesting because I can't really do that when I'm in person looking at their airway. I can't really show them their own airway unless I have a mirror or I take a picture with my phone. But this way I can share the screenshot during our visit and then I delete it. And then, it's been interesting. And then they can also see the picture that I can see. And I think it gives it more legitimacy almost. I don't know. We've been experimenting a lot. Every day it's different.
Yeah.
And sometimes my one platform won't work. It'll be really laggy. And then I'll call on another one on my phone. And then I'll have to do this. And then I'll have to do that. And every so often I'll be like, I'm just going to call you. And I'll just pick up my phone and call them. So it's been really interesting. And I've enjoyed seeing how patients that I've known forever have adapted to it, and even new patients. It's been really interesting to see how, we all do have to figure out how to do this, right? Because we have to figure out our new normal.
Right, exactly. I totally feel the same. And some patients actually quite enjoy it. And myself kind of enjoy the exploration with them together and figure out technical issues together. And try to, because now it's telemedicine, sometimes we can definitely do more. Like I see children also. With children, sometimes they're so excited to share their screen with me, to share some games they're playing, some YouTube videos with me, which is not happening in the office.
Oh my gosh. How adorable is that though? So they're more engaged.
Yeah, in ways, many of them would love to show me their room, which means a lot for children want to share to a provider that their little secret, their toys they love, they want to share, they would love to talk. Some parents are surprised because some parents told me their children actually never Skype or video talk with any family member for more than 15 minutes before, but they could stay in session for a whole 45 or 50 minutes and don't want to stop.
Oh
while we are still deliver some intervention in a fun way. So it's interesting.
Isn't that, and I find that it's kind of made us challenge, why we do things, but also I think it makes us a little bit more creative in terms of, what we want to see. So I've kind of enjoyed that too. I had a lady that showed me her legs and showed me how swollen they were. And she,
Mm.
I kind of guided her to, well, push your finger in and let's see what it looks like. And she can show it to me. And even just looking at the side of somebody's face, you can see if their jaw sits back a little bit. And you're like, oh, you know what? That's a risk factor for sleep apnea.
Mm.
Or you talk about, like you share your screen and you review the data, or you review this new cool thing that came out, or they have their fitness tracker, right? And then you can share, and you can ask to see their screen too. And so it's been this exploration that's been really, I mean, yes, frustrating sometime, of course. I have two kids that are distance learning, and so they both have, Google Hangouts, and
Mm.
then I'm trying to do telemedicine. So, we've upgraded our internet twice since
Oh.
COVID happened. And and I called and she's like, "You cannot possibly be having problems." She's like, "You're on the most like hugest bandwidth we have." And so like you can't possibly be having problems still. And I'm like, I am. And so and so it's just that part's been interesting. I have these two dogs, and so they will sometimes try to make a guest appearance, and I'm trying to get them out of the way without letting on that I've got this giant dog that's trying to get in my lap. And so but I think most, especially for patients that I've known, I think it's a little bit different because they already know you and they kind of, you have that relationship with them. I did have a guy the other day that I first met him on a telemedicine visit in his home. I met his grandkid and his dog, and we sent out a home test to him, and he had sleep apnea. And so yesterday I saw him full circle. So I saw him before he had been diagnosed, and then I reviewed the test with him. I reviewed his CPAP information. We answered questions, and he had lost 10 pounds since
Wow.
he's been on CPAP. He felt pretty good. He had his complaints about the mask and things like that, which I totally get. but but it was kind of, that was the first person that I had done that full circle with. And so I thought that was really kind of a milestone that we've been doing this long enough to have circled back around with our patients, and to sort of check in with them to see how things are going.
Yeah. Wow. That's amazing to be able to see them and be with them this whole journey, mostly through telemedicine.
Right.
Yeah.
Right. And for the first, so yesterday, I had a lady, and I've known her for years, but she was having trouble with her machine. It was giving her a headache, and she'd already stopped wearing it. And so we kind of talked about this, because she's in a higher risk group for COVID.
Mm. Mm.
And we talked about, well, you know what, you've already stopped using it. Let's maybe check in. And I've never been able to do this, but I can see her next week
Mm.
because A, I have room in my clinic now. And B, it can be, I don't have to feel guilty that I'm, putting her in a car and asking her to drive.
Mm.
She can
Right.
pick up the phone and it
Right.
takes, like 15 minutes or 20 minutes, and it's not a big deal. I can do it over lunch. It's kind of, I can't remember in the last decade ever being able to bring somebody back next week. Like that just never
Yeah.
happens. And so that's been really interesting. I'll have to see how she's doing next week, but that's been kind of cool.
Yeah, give us a lot of flexibility and much better patient care in a way that they don't have to schedule time to really come in. It's phone call away. There's a way to figure that out. That's
Right.
amazing.
But
Yeah.
I do think that it has kind of uncovered these sort of the social determinants of health disparities. So I have a patient that we've been trying to get in. She doesn't have a smartphone. She doesn't have a computer. She doesn't have anything like that. So we're just doing a regular phone call for her. And so you can definitely see that people who have access to this technology are, they're advantaged, right? and
Hmm.
and they get to play and they get to be part of this new paradigm, and the people who don't have access to it, it feels like almost like another door is being shut on them, right? It's
Mm.
another thing they don't get to engage in, and it puts them further and further sort of on the outside of what we're paying attention to, and
Right.
that bothers me. And I don't know. I've been looking into their companies that will mail out like a tablet and an ear thermometer, and I can't remember, something to look in your ear and nose or something. I don't remember. But they'll mail it to somebody, and they'll have a little MiFi so that they can convert like cell signal into internet signal for that device. And I mean, it's interesting. Right? And is that a way to do it? But then, is that covered by insurance? Like how do you get over all those barriers, right? And how do you still help your patients?
Yeah, all those barriers feels like are something all of the professionals are trying to figure out how to do good patient care, and do all this testing, all this basic examination done without seeing them in person, and make it also easier for, especially I would say, older patients or patients have some cognitive challenge. It's going to be hard for them to master all these new things and how to use things and how to follow instructions.
Well, especially if they don't have that support from, somebody that can help them.
Right.
And it all goes back down to that, who are the people that seem to do better? It's people who have support of some sorts, right? If it's a spouse or a friend or a whoever, and yet when you're by yourself and you're trying to navigate through some of this, and I think it's been so interesting that I've had some older people that do really, really well with telemedicine. They are all over it. And then I've had some younger people that struggled, and that was so surprising to me. I did not anticipate that. We have done telemedicine for, like 10 years. But it was very sort of formal, where our staff would go out to where, a town where the patient is. And then we would see like all the patients from that town that day that had an appointment. And so there physically was somebody from our office that would greet them and take their vitals and kind of have that contact with the patient. And so this has been different than that. So that's been interesting.
Yeah.
But even some of the lessons that we learned from doing telemedicine, I've still had to learn and adapt, even though I feel like I've got this, previous experience with telemedicine. This still made us evaluate what we're doing. And do I really need to have this bit of data that I can only get in person or from my nurse, right? And so it's another iteration where we're trying to figure it out. And yet above you always check in with your patient, and is this working for you? I mean, it's less important if it's working for me. It's more important that my patient's getting something out of it, because I'm pretty adaptable, right? Like, okay, this isn't working, let's try this. Okay, let's try FaceTime. Okay, let's try whatever. I don't care. Let's whatever you want to do is fine with me. But I don't want to alienate patients if they don't have access to technology. I don't want them to feel sort of scared to do it. And so we're trying to make it as easy as possible.
Yeah. So happy to hear that you guys are trying so hard. And hopefully this will get easier and easier, and a lot of new ways will come out to really help people with different levels, familiarity with technology. And one thing I want to ask you is, I know you are hosting actually a new podcast about sleep, which is very, very exciting.
It is exciting. And I am the first to admit that I am just trying to learn. So we with the AASM, the American Academy of Sleep Medicine, they do a really nice job with a lot of education. So they had an education committee. ASM committees are volunteer physicians. And once a month they get together. So for example, I had a technology, and I was chair of the technology committee, and there's an education committee, and there's a public safety committee, and there's tons of these committees. And so the education committee did these interviews with different people in the sleep field. And so we are highlighting those interviews in this first season of podcast. And we're trying to learn, at least I am. The ASM folks, they know how to do all this stuff, but I am learning. And so we're trying to figure out, what is interesting for people. what do people want to hear?
Mm-hmm.
What format should it take? Should it be more interviewing people within the sort of ASM orbit, or should we go outside of people within the ASM and really explore and engage with other people in the sleep community, research people and technologists and industry, right? Like fitness trackers and all of that. So I am actually really excited to learn from you because we've recorded about 5 podcasts.
Oh, great.
And so, but mostly it's highlighting the work that the education committee has already done. And so then the next season will be what we have we'll take those lessons and then we'll try to kind of turn it into what we envision moving forward.
Oh, great. So is that a podcast designed for sleep professionals or professionals in healthcare field? Is there certain ideas about, is that for general public or more professionals?
So you're right. It is geared towards sleep professionals. But one thing that I've learned is that a lot of our patients are really, really smart about sleep. And so I wouldn't say exclusively for sleep professionals. I've had some really enlightened conversations with patients and with people outside of the sleep world that have this impressive knowledge about sleep. And so we welcome people to listen, if they can get something out of it, great. I think the more people that talk about sleep, I think that's a win for all of us. And so
yes.
if there's 20 podcasts that talk about sleep, I'm like, that's fantastic. Maybe people will start to really kind of understand this message about how important sleep is. Right. And what we need to do. If we can be part of that, we are totally thrilled to be part of that. And if we can reach out to sleep professionals and expand our reach a little bit, for anybody that is willing to listen to us, we would welcome that.
Yeah, that's awesome. So if people are curious to check out this new podcast, how can they find this podcast?
So it's called Talking Sleep. It is available on the AASM website, aasm.org, if you're a member. It's also available anywhere you look for podcasts.
Great. Yeah, I will put the links to the website. So whoever listens to this episode, listen to our conversation, will have access will be able to find that podcast and download it to listen. Also, if people, are curious about your practice, they want to read more, or they are local in your area, want to go to your practice to see you, how can they find you?
Oh, well, I would love to tell you we have a robust website, but we don't. But we are the North Dakota Center for Sleep in Fargo. If you're looking for a lab outside of Fargo, MedBridge Healthcare has labs in many, I think 22 different states. And so that would be a good resource. And that one actually has a website, medbridgehealthcare.com. But no, my clinic is just small. It's just me. I've got my clinic manager, and we call ourselves a dynamic duo. And that's kind of how we have a very small practice, and we spend time with our patients, and we really try to be patient advocates.
Great. Yeah, great to know. With website or just the name, local people can find it. That's all very helpful. And I think it's very helpful for me. I also learn a lot from our conversation. I'm sure the audience will, to learn more about different sleep disorders and under COVID, what we can do with the testing, with the treatment. That's awesome. So all this website you talk about and the name of your practice, I will put them all on the show note, so people will have access to those.
That's fantastic. Thank you. I appreciate that.
Yeah, thank you very much, Dr. Khosla, for your time to be on the show, sharing all this expertise with our audience.
I appreciate it. Thank you for having me.
Thank you very much for listening to today's episode. Hopefully, our conversation can inspire you, give you more ideas about a sleep center and sleep study under COVID. So if you want to find more information about Dr. Khosla's practice, or you're curious about the new a podcast hosted by AASM, you can find that information on our show note at deepintosleep.co/episode/040. Again, if you have any questions, welcome to email me or leave a message on our website, and I will try to get back to you as soon as possible. If you have any other topics you're curious about, you really want to listen to, also welcome to let me know. Thank you very much for listening to our episode today. I am Yishan, and I will see you next week.
Sleep is an individual thing. We all sleep differently, and there is so much we can do to improve sleep quality. Keep hope and carry on. This podcast is for general informational purpose only and does not include the practice of medicine or other health professional services. Usage of the information we share is at the listener's own risk, and our content does not intend to be a substitute for any medical and professional services, diagnoses, and treatment. Please seek professional health services as needed.